Well, it's a pleasure to be here. So here are my disclosures. None of the disclosures are relevant to the talk I'll give today. I'm going to skip the background because everyone in this room knows this slide better than I do. I think you all are well aware of the difficulties of treating NF2. And we just had a wonderful summary of the current treatment options, none of which are really very good, unfortunately. It's hard for me to say that as a surgeon, but it's true. One of the things that we all know is that cutaneous lesions or skin lesions in NF2 are quite common. They appear in different forms. Usually they're lower on the list of priorities. They're not something that most people have a lot of trouble with. Some are sensitive, some can cause disfiguration, but generally we don't talk too much about treating these tumors. Here's one in the scalp on the left, and here's one on the back, and another patient. A few other tumors that I've taken, this is my poor photography with my iPhone. I need to get a new iPhone, my old one's not so good. But you can see a lot of different types of cutaneous and subcutaneous lesions. And as have been described earlier, you all know that these tumors arise from the covering of the Schwann cells. This is a nerve, and there are multiple axons within the nerve. Oh, my pointer is, oh, I see, I'm on the wrong screen. Gotcha, gotcha, I'm over there now. Okay, thank you. Yeah, so I'm on the wrong screen, there we go. So if we have a nerve here, and it has multiple bundles in it, and inside of each one of these, there's a little axon, and the cells that wrap around the nerves are the Schwann cells. And when we're talking about these particular type of skin tumors, they're made of Schwannomas, they're Schwann cells. There are a number of other different type of neural tumors that we all are familiar with, but the ones particularly we're interested in today are the Schwann cells. In NF1, of course, cut off a little, but in F1, there are neurofibromas. They're not only the Schwann cells, but there are also fibrous tissue that gets mixed in with these tumors. But in the neurofibromatosis type 2 and Schwannomatosis, we see these nice little lined up cells that are all Schwann cells. And this trial is that we've initiated with the help of the NF Northeast is to look at directly injecting cutaneous tumors with doxycycline, which is an antibiotic. And so most of you will be scratching your head saying, why are you using an antibiotic for a tumor? Well, one thing is it's a new route of drug delivery. We haven't done that too much. Secondly, it's potentially a new mechanism of tumor control because doxycycline is also known to cause scarring or sclerosis of tissues. I'll show you some reasons for this. And then it also may have some potential tumor growth inhibition as well, such as with vascular endothelial growth factor. It may cut down blood vessels to the tumors. The idea for this originated with one of our collaborators, Dr. David Shea, who does a lot of work in Africa. And this is a child that was born with a cystic hygroma, which is a tumor that has a lot of lymphatic vessels in it, and it can cause compression of the airway. And they have very limited resources in Rwanda where this occurred. And so he was looking for some way to treat this other than with surgery, which is not really available to them. He found a doxycycline antibiotic tablet and crushed it up and put it in saline and injected this into the tumor. And the results 1 year later are shown on the right. You can see a little bit of baggy skin here, but the cystic hygroma is gone. And he has now a dozen or so children that he's injected this. And I thought, well, that's interesting, you know, that this would cause such a remarkable collapse of these cystic spaces. Cystic hygromas are fairly common, and they are associated with some other genetic syndromes, but not to focus on cystic hygromas today. I'll just show you, this is the child's CAT scan. And you can see what a large collection of fluid was here. And it was also compressing the baby's airway. And so reducing this was important for their livelihood. When we look at these tumors histologically, they have fluid-filled spaces in them. And these fluid-filled spaces are what we think gets scarred down with the injection of the doxycycline. And so when we started looking into doxycycline a little bit, thinking, would this possibly be useful for some of our tumors? Well, there are a number of different types of lesions that can be treated with doxycycline. And some activity against various cancers has also been shown with doxycycline. I've listed a bunch of them here. But interestingly, doxycycline can be injected for people like me who have big bags under their eyes. You can inject it and it helps them to sclerose. You've seen a lymphangioma. People who get pleural effusions, who get a collection of fluid in their lung, also sometimes can have doxycycline injected to cause a scarring to help keep the lung open. And then also there's interesting aneurysmal bone cyst, which is a big collection of blood vessels that form around the roots of teeth and other places in the body, can also be treated with sclerosis from doxycycline. Now, interestingly, there are a number of different tumor types that also show some evidence that doxycycline involves some of the different pathways that help to reduce these tumors from growing. And I don't think doxycycline is used alone to treat any of these tumors, but in the Petri dish in culture, there are evidences that show that doxycycline may have an effect in a number of different cancers. Well, what about in NF2 related tumors? We know that in vitro or in a Petri dish, doxycycline inhibits a group of proteins called metalloproteinases that are upregulated in vestibular schwannomas. It also blocks the extracellular matrix, the area around the tumors, and it keeps them from getting degraded. It may suppress vascular endothelial growth factor, which we know is the target of bevacizumab. And that may be an interesting way to think about potentially treating these tumors, is to block blood vessels getting into them. We know it also involves regulation of the inflammatory process. And we haven't talked about that too much today, but inflammation is one of the things that drives these tumors. And knowing how to regulate the inflammatory process may also be quite helpful. There is a particular group of inflammatory regulators, this NF3P inflammasome, that's a NLRP3 inflammasome that's activated in vestibular schwannomas. This is a slide of a vestibular schwannoma. And in the upper left corner, you can see cells that are very tightly packed, and they kind of form in rows. And on the right side are cells that are loosely connected. These are the Antony B, these are the Antony A type of patterns. It seems to me that if something's going to cause sclerosis in an Antony B where there's a lot of loose matrix, it may actually cause that part of the tumor to shrink up. That would be a win. Now, there are certain cystic type of schwannomas that actually have a lot of fluid in them and look very similar in some ways to the big neck tumor I showed you a minute ago. And these cystic schwannomas can have a lot of compression against the brainstem when they're filled with fluid. And if we were able to inject these tumors and cause them to scar up and shrink down, that would also be a fairly less invasive way of treating these than taking them out surgically. So those are the reasons that I thought this might be an interesting pilot to explore. So our study design is an open label interventional single treatment pilot study. And each person who enrolls in the study can have up to 3 tumors treated. We didn't want one person to get all of the fun. We've targeted up to a total of 19 tumors. And the outcome will be the tumor size after 6 months. So a response would be considered shrinking of the tumor by 25% in diameter. Failure would be growth by 25% and indeterminate if it doesn't change much. These tumors don't usually change very rapidly, so we're hoping that we won't see too many grow. We will consider it a successful pilot trial if we see 4 tumors that regress by 25% or more. And if that's the case, then we'll go on and do a more detailed study. The secondary outcomes, of course, there have been some different ways of measuring the tumors we'd like to explore. We want to know if injecting these tumors causes numbness or irritation of the skin, pain, itching, redness, discoloration. There's been a recommended endpoint from the RAINS group about how to measure these, and we will do that as well. Right now, we're just measuring these by electronic calipers or by MRI scans. We also are giving a little bit of pretreatment lidocaine to help reduce the amount of stinging. Some people in the room can tell you it does sting when we inject these. Our timeline was here. The IRB approval, that little green blip, that was a gross underestimation. They made us go to the FDA to approve this, so that's always the case. But anyway, we hope this won't take a long time to accomplish, including the 19 patients. Inclusion criteria are listed here. Patients with confirmed NF2 schwannomatosis that are 8 years of age or older. They have to have lesions that are between 0.5 centimeter and 4 centimeters, so we can measure them, but they're not too huge. And the maximum of 3 tumors I mentioned. All these other things are just part of the thing that we have to put in the grant proposals. The exclusion criteria, of course, any allergies to doxycycline or tetracycline, which is related to doxycycline. We don't want to inject any tumors on the face or any major motor nerves until we understand a little better what doxycycline is doing to them. And the third point, current anti-cancer therapies, is actually one that we're bumped into, and we hadn't maybe thought carefully enough about this, but many patients who have cutaneous lesions are already on bevacizumab, or were on brigatinib, or on other basket trials, and it's a little bit limiting. We do have patients that have not been initiated on those who can participate, but given this is a pilot, we'll see how things go. We may or may not consider relaxing that particular criteria, but we don't want tumors that have been radiated, prior treatment of investigational drugs and so forth. So this is the simple schema. Patients come in, they will be evaluated, and if they have lesions that qualify, we'll inject them with doxycycline, and we'll get a response evaluation at 6 months. We'd also like to see how they're doing at 1 year. Risks to the study, there are unknown side effects. We don't really know if doxycycline works for these tumors. We really can't tell if it's going to be helpful or not. Numbness, tingling, itching, burning, skin discoloration, bruising, skin breakdown or scabbing. And the one that we always have to put in for the IRB, the Investigational Review Board, is you could lose loss of privacy. Somebody else might see the record and find out who it's associated with. So we try to be very careful about that. We lock the records in the computers and offices and so forth. So accrual to date, we have 4 patients who are officially in the trial. We've injected 7 tumors. We need 12 more tumors to complete the pilot study. So far, our observations are these. There's a great variety in NF2-associated cutaneous schwannomas. Some are like a bag of worms. Some are very firm and hard like a rock. Some are flat with skin discoloration. We're dealing with quite a broad set of different tumors, even though we've lumped them all under one category here. And many patients are on other chemotherapies right now. One complication so far, in the very first injection, I'm going to show you this. I learned about how to inject these a little more safely. This is a fellow who had schwannoma on his elbow that it's hard to see, but you could feel it here. And when I did the first injection, I had more doxycycline in the syringe than I had figured the volume to be. And it was difficult as the needle went into the tumor to get it to start injecting. And as I pulled back, it injected more than I had calculated. So now what we really want to do is go into the tumor and make multiple passes through the tumor. And we only load up enough doxycycline in the syringe that we meet the volume that we've calculated. This gentleman got more, and you see he got a scab on his elbow. And then when the scab resolved, he has a little bit of an indentation there. I don't think he has much tumor there, but it may be that we over-injected that one. Our long-term goal is to find better treatment options, of course, and reduce morbidity. Maybe we'll get to the point where we could use this for intracranial or spinal schwannomas. That's the goal. And of course, the final goal is what Scott talked about earlier, is we want to cure NF2. And so probably this is an intermediate step. I think giving the gene back would actually be a more comprehensive approach. So we have a new delivery method. We're working on it. New mechanisms of potential benefit, targeting different pathways, sclerosis of the tissue, and cutting off blood supply. So we encourage participation. If any of you are interested or know people who might be interested, please let us know. And thanks to NF Northeast for funding this for us. Here's contact information. Dr. Jordan and I are both on this. Allie Brown is our coordinator for a few more weeks before she goes off to medical school. And Dr. Brenner, Dr. Shea, Dr. Kuman's here, all are co-investigators. So thank you for your kind attention. And I'll leave you with this view of my family. You'll be surprised we could have our own clinical trial.